Hello everyone, welcome to sqadia.com. My name is Hira Imran and today we will talk about acute shoulder pain, or it's also known as impingement syndrome, and we will talk about the different rotator cuff muscle tendons which are attached to the humerus and how the tendons can be impinged due to some anatomical variations, like there can be some hooked acromion, or the acromion surface can be a bit thicker than normal, which will obviously impinge or compress the structures passing beneath the acromion. So that will result in impingement of the tendons, which can ultimately rupture. So that is all that we're going to talk about in the impingement syndrome. So let's take an overview of what we're going to discuss. So in acute shoulder pain, like I said, we will start with, we will talk about how structures can be impinged due to some anatomical variations, and to actually identify an anatomical abnormality, you should know the anatomical normality of the entire region. So first we will talk about the shoulder anatomy, all the structures that are present in the region, and we will talk about them in detail, and we will look at them in every radiograph along the entire process, and in explaining all the fractures, I'll also be showing the anatomy of all the structures and how they appear on radiographs. So then we will move to shoulder trauma and how traumatic shoulder region appears on radiographs, and in acute conditions when radiographs are taken, how they appear. So we're going to talk about that. Then we will talk about the dislocation of glenohumeral joint, the most common being the inferior dislocation of the humerus. So we will talk about that in detail in the lecture. So then we have a humeral shaft fracture, which we will see in different radiographs and how they appear, and there can be comminuted, they can be single through and through fracture, single line, they can be irregular. We will see different radiographs, and we'll talk about them. Then we will talk about clavicular fractures, and they can be medial, they can be distal, they can be comminuted, they can be irregular. We will also see them on radiographs on different views, AP and PA. Mostly for clavicle, AP view is used, but for humerus and glenohumeral joint, different views are used, and we will talk about that. So for scapula also, different views can be used, but mostly we use the PA view, which is used to visualize scapula better. So we will see the scapular fractures. Also the Y view is suggestive for anybody who is thought to be having some scapular fracture or abnormality. So Y view also also shows scapular fractures quite clearly. So then we will, all along this entire process, we will be interpreting every fracture on the radiographs, so that will make it very easy. So interpretations are not in separation, they're actually in the entire process of the lecture. We'll talk about every disease and or abnormality or lesion and how it appears on the radiograph or the MRI. We'll focus on these two radiological modalities, the MRI and CT and the X-ray, and the X-ray for this lecture today. So that is it for today, and thank you for watching. I hope you enjoy the lecture.